Hi, I'm Dr. Mike McInnes. I'm one of the chief educators at Doctors in Training, and I want to welcome you to the Solid Anatomy video on the abdominal organs, Part 3. So in Parts 1 and 2, we discussed the organs themselves. But in this video, we're going to cover the blood supply, the innervation, and the lymphatic drainage of those organs. Now, I'll be back a little bit later for a clinical correlation for your end-of-session quiz. But for right now, I'm going to turn you over to our primary lecturer, Dr. John Phelan.
The blood supply to most of the digestive tract and to the intraperitoneal abdominal viscera is provided by three branches from the abdominal aorta: the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. The branches of all of these arteries reach their target organs by passing between the sheets of the peritoneum, forming the mesenteries of these organs. The remaining branches of the abdominal aorta will be described in the Solid Anatomy lecture on the posterior abdominal wall and viscera. The celiac trunk supplies structures that arose from the foregut of the embryo, namely the esophagus, the stomach, the liver, the gallbladder, and part of the duodenum and pancreas. The celiac trunk usually gives off three branches: the splenic, the left gastric, and the common hepatic. The splenic artery runs adjacent to the superior edge of the pancreas and gives off branches to its body and tail. As the splenic artery approaches the hilum of the spleen, it gives off multiple short gastric arteries that feed the fundus of the stomach, and the left gastroomental artery that proceeds inferiorly to follow the greater curvature of the stomach. Multiple branches to the stomach arise along the length of the left gastroomental artery. Distally, the splenic artery divides into multiple branches that enter the hilum of the spleen on its visceral surface. The left gastric artery follows the lesser curvature of the stomach and sends branches to the stomach along its length. It also sends branches to the esophagus. The common hepatic artery bifurcates into the gastroduodenal artery and the hepatic artery proper, or proper hepatic artery. The gastroduodenal artery bifurcates into the superior pancreaticoduodenal artery and the right gastroomental artery. The right gastroomental artery follows the greater curvature of the stomach, sending branches to the stomach along its length and anastomoses at a variable point along the curvature with the left gastroomental artery. The gastroomental arteries run between the anterior two layers of the greater omentum. Recall from earlier in the lecture that the greater omentum consists of a pair of double layers of peritoneum. The superior pancreaticoduodenal artery bifurcates around the head of the pancreas into an anterior and a posterior branch. As its name suggests, the artery feeds the head of the pancreas and the duodenum. The hepatic artery proper runs in the hepatoduodenal ligament, which is the part of the lesser omentum that forms the superior edge of the omental foramen, with the other components of the portal triad: the common bile duct to the right and the portal vein posteriorly. The hepatic artery proper gives off the right gastric artery, which follows the lesser curvature of the stomach, giving branches to the stomach along its length, and anastomoses with the left gastric artery. The gastric arteries run between the layers of the lesser omentum. Distally, the hepatic artery proper bifurcates into the right and left hepatic arteries. The right hepatic artery delivers the cystic artery to the gallbladder. The right and left hepatic arteries then enter their respective lobes of the liver. Recall from our earlier discussion of the liver that this organ is nourished not only by blood from the hepatic arteries, but also by the nutrient-rich blood from the gut carried to it by the portal vein. The superior mesenteric artery supplies structures that arose from the midgut of the embryo, that is, part of the pancreas and duodenum, the jejunum, the ileum, the cecum, the appendix, the ascending colon, and the proximal half of the transverse colon. Usually, the first branch off of the superior mesenteric artery is the inferior pancreaticoduodenal artery, which bifurcates around the head of the pancreas into anterior and posterior branches. The branches of the inferior pancreaticoduodenal artery anastomose with the branches of the superior pancreatico-duodenal artery. Next, jejunal and ileal branches, or just intestinal branches, usually 15 to 18 in number, arise from the superior mesenteric artery and run through the mesentery to the small intestine. As they approach the small intestine, the intestinal branches form a network of small loops called arcades. The ileum has more layers of arcades than the jejunum, but the arteries to the jejunum are wider, and the jejunum is said to be more vascularized than the ileum. Extending from the arcades are vasa recta, arterial branches traveling straight to the small intestine. The vasa recta of the ileum are shorter than those of the jejunum. The remaining branches of the superior mesenteric artery are the ileocholic, right cholic, and middle cholic. The ileocholic supplies the distal ileum, the cecum, and the appendix. The ascending colon is supplied by the ileocholic and right cholic arteries, while the proximal part of the transverse colon is supplied by the middle cholic artery. The inferior mesenteric artery supplies structures that arose from the hindgut of the embryo, namely the distal part of the transverse colon, the descending colon, the sigmoid colon, and the proximal part of the rectum. The first branch of the inferior mesenteric artery is the left cholic artery, which anastomoses with the middle cholic artery and supplies the distal part of the transverse colon and the descending colon. Next, 2 or 3 sigmoid arteries arise from the inferior mesenteric artery and supply the sigmoid colon. The terminal branch of the inferior mesenteric artery is the superior rectal artery, which follows the gastrointestinal tract into the pelvis to supply the superior part of the rectum. Wide loops, or arcades, form anastomoses among the ileocholic, right cholic, middle cholic, left cholic, and sigmoid arteries and give rise to the marginal artery, a continuous artery running within the mesentery along the concave margin of the large intestine. The veins draining the abdominal organs are, for the most part, named identically to the arteries that feed them. Most of the venous drainage of the structures supplied by the celiac trunk and the superior and inferior mesenteric arteries ultimately leads to the portal vein. The splenic vein, which receives blood from organs supplied by the splenic artery, and the superior mesenteric vein, which drains blood from the structures supplied by the superior mesenteric artery, unite posterior to the neck of the pancreas at about the level of L1 to form the portal vein. The inferior mesenteric vein, which drains structures supplied by the inferior mesenteric artery, usually drains into the splenic vein, but may drain into the superior mesenteric vein or into the junction of the splenic and superior mesenteric veins. As for the veins draining the structures supplied by the left gastric and common hepatic arteries, the left and right gastric veins and the superior pancreatico-duodenal vein empty directly into the portal vein, while the right gastroomental vein empties into the superior mesenteric vein. Which leaves us with the liver. As mentioned previously, the portal vein travels in the hepatoduodenal ligament inferior to the other components of the portal triad, the cystic duct on the right and the hepatic artery proper on the left. The portal vein bifurcates into left and right branches as it enters the liver on its visceral surface through the porta hepatis. Blood carried by the portal vein is cleaned and detoxified by the liver and delivered via the hepatic veins to the inferior vena cava, which returns it to the heart.
Welcome back. Now, I want you to pay particular attention to the venous drainage here because it's going to be important to understanding some key concepts that relate to the presentation of cirrhosis. Now, when the liver is damaged, for instance, from chronic alcohol abuse or from chronic hepatitis, the liver can become scarred and fibrosed, and we call this process cirrhosis. And all that cirrhosis and scarring makes it difficult for blood to flow through the liver, so that the pressure builds up in the portal system. We call that portal hypertension. So when the blood pressure in the portal vein becomes elevated, blood may start to back up through the portal vein and flow through one of the 4 portocaval anastomoses in the body. Now, as the name implies, a portocaval anastomosis is an anastomosis between the portal circulation and the systemic circulation, which goes through the superior or inferior vena cava. So it's the caval circulation or the systemic circulation, the same thing. Now, these portocaval anastomoses may also be referred to as portosystemic or portal systemic anastomoses. Now, these anastomoses represent a potential path of collateral circulation around the liver, sometimes referred to as a bypass or a shunt, whereby blood from the GI tract can return to the systemic circulation without having to pass through that cirrhotic liver. And these anastomoses are also potential sites of varicose vein development. Now, the four main sites of portocaval anastomoses are the esophagus, the umbilicus, the rectum, and then the surfaces of the secondarily retroperitoneal viscera that are in contact with the posterior abdominal wall. Now, there's an extensive anastomotic network of submucosal veins all along the length of the esophagus. And these submucosal veins of the thoracic portion of the esophagus drain via the esophageal veins into the azygous vein, which connects to the superior vena cava in the thorax. And it also connects to the inferior vena cava in the abdomen. And the submucosal veins of the abdominal portion of the esophagus drain via the esophageal branches of the gastric veins into the portal vein. So when you have portal hypertension and blood starts backing up from the portal vein, it can enter the gastric veins and ultimately empty into the network of submucosal esophageal veins. From here, the portal vein may drain via the esophageal veins to the azygous vein and then to the vena cava. Thus, by following this pathway, blood from the gut is able to enter the caval system, that systemic circulation, without passing through the liver. If blood backs up into the submucosal veins faster than it can drain into the azygous vein, these submucosal veins may become dilated, forming esophageal varices, or varicose veins within the esophagus. Those are in danger of rupturing. Now, another potential site of portocaval anastomosis is the umbilicus. Now, if you've watched the solid anatomy video on the anterior abdominal wall, you're probably already familiar with this. The paraumbilical vein extends from the left portal vein to the umbilicus via the falciform ligament. Here, branches of the paraumbilical vein anastomose with branches of the superior and inferior epigastric veins. The superior epigastric vein empties into the internal thoracic vein, which empties into the brachiocephalic vein, which merges with the brachiocephalic vein coming from the other side to form the superior vena cava. The inferior epigastric vein drains into the external iliac vein, which merges with the internal iliac vein to form the common iliac vein, which combines with the common iliac vein from the other side to form the inferior vena cava. Thus, we have another pathway for blood from the gut to bypass the liver and enter the caval system. Subcutaneous veins of the anterior abdominal wall, such as the superficial epigastric vein, also join this anastomotic venous network at the level of the umbilicus. And again, if blood backs up from the portal vein through the paraumbilical vein faster than it drains into the epigastric veins, these subcutaneous veins radiating from the umbilicus become distended, which leads to the appearance of something called a caput medusa, which is where the superficial veins of the anterior abdominal wall bulge under the skin and resemble the snakes on Medusa's head. The third site of portocaval anastomosis is the rectum. The rectum has extensive portal and systemic venous drainage. The superior part of the rectum is drained by the superior rectal vein, which empties into the inferior mesenteric vein. As mentioned previously, the inferior mesenteric vein may either join the splenic vein or the union of the splenic vein and the superior mesenteric vein, which ultimately leads to the portal vein. The inferior part of the rectum is drained by the middle and inferior rectal veins. The middle rectal vein drains into the internal iliac vein, which again combines with the external iliac vein to form the common iliac vein, and that merges with the common iliac vein from the other side to form the inferior vena cava. The inferior rectal vein drains into the internal pudendal vein, which is also a tributary of the internal iliac. So the superior, middle, and inferior rectal veins anastomose with each other all along the rectum and the anal canal, so that blood backing up through the portal vein can bypass the liver by passing through this anastomotic network to enter the inferior vena cava. The varicosities that may result from the engorgement of this anastomotic network are called hemorrhoids. The fourth and final site of portocaval anastomosis is on the posterior surfaces of the secondarily retroperitoneal organs, specifically the ascending and descending colon, the duodenum, and the pancreas. Venous drainage of these organs occurs via the portal system as described previously, and also via variable retroperitoneal veins that extend across the posterior abdominal wall to the inferior vena cava. So be aware of these portocaval anastomoses and the physical findings associated with cirrhosis and portal hypertension. Now let's get back to Dr. Phelan to discuss lymphatic drainage.
Lymphatic drainage of the abdominal viscera begins with lymphatic capillaries that run from each of the individual organs. Recall from our earlier discussion of the liver that some of the plasma that leaks out of the sinusoids is collected by the liver's lymphatic capillaries. Over a quarter of the lymph in the body is generated this way. Also worth noting is that the lymphatic capillaries of the small intestine, which are found in the core of the villi, are called lacteals. The lacteals take up digestive fat and carry it into the lymph, and ultimately into the venous circulation. The lymphatic vessels of the individual abdominal organs drain into the visceral lymph nodes, which are found near the organs, and in the mesenteries in association with the arteries and veins supplying the organs. Lymph drains from the visceral nodes via lymphatic vessels that follow the arteries and veins through the mesenteries to the posterior abdominal wall. These vessels empty into parietal lymph nodes, which are found along the lengths of the aorta, the inferior vena cava, and the common iliac vessels. The parietal lymph nodes form clusters surrounding the origins of the celiac trunk and the superior and inferior mesenteric arteries. The pattern of lymphatic drainage to the parietal lymph nodes is similar to the blood supply to the viscera. Lymph from the stomach, duodenum, pancreas, spleen, and liver collects in the celiac lymph nodes. Lymph from the jejunum, ileum, cecum, appendix, ascending colon, and transverse colon collects in the superior mesenteric lymph nodes. And lymph from the descending colon, sigmoid colon, and rectum collects in the inferior mesenteric lymph nodes. Lymph that collects in the celiac and superior mesenteric nodes drains into the intestinal trunk, while that which collects in the inferior mesenteric nodes drains into the left lumbar trunk. The intestinal trunk and left lumbar trunk drain into the cisterna chyli, the dilated origin of the thoracic duct found at about the level of the second lumbar vertebra. The thoracic duct ascends into the thorax through the aortic hiatus. If you've watched the solid anatomy lecture on the thoracic wall, you may recall that the thoracic duct passes through the posterior mediastinum between the aorta and the azygous vein, continues through the superior mediastinum, and enters the neck, where it joins the venous system in the vicinity of the junction of the left subclavian and left internal jugular veins. The autonomic nervous supply to the abdominal viscera is provided by the aortic plexus, which is formed by preganglionic, sympathetic, and parasympathetic nerve fibers surrounding the abdominal aorta. Preganglionic, sympathetic efferent nerve fibers in the aortic plexus come from the greater, lesser, least, and lumbar splanchnic nerves. The nerve fibers carried by these splanchnic nerves all originate in the lateral horn of the gray matter of the spinal cord. The greater splanchnic nerve carries fibers originating from spinal cord levels T5 through T9. The lesser splanchnic carries fibers from T10 and T11. The least splanchnic nerve carries fibers from T12, and the lumbar splanchnic nerves carry preganglionic sympathetic nerve fibers that originate at the L1 and L2 spinal cord levels. The greater, lesser, and least splanchnic nerves branch from the sympathetic trunks in the thorax and enter the abdomen by passing between the diaphragm and the posterior abdominal wall, while the lumbar splanchnic nerves branch from the sympathetic trunks in the abdomen. More information on the sympathetic nervous system is available in the Solid Anatomy lecture on the thoracic wall. Preganglionic parasympathetic efferent nerve fibers supplying the abdominal viscera come from the vagus nerve, which is the 10th cranial nerve, and from the pelvic splanchnic nerves, which arise from sacral spinal cord levels 2, 3, and 4. The right and left vagus nerves branch to form the esophageal plexus in the thorax that gives rise to the anterior and posterior vagal trunks. The vagal trunks enter the abdomen through the esophageal hiatus with the esophagus. The pelvic splanchnic nerves branch from the ventral rami of the sacral spinal nerves in the pelvis and enter the inferior hypogastric plexus, which will be discussed in the solid anatomy lectures on the pelvis. Some of the pelvic splanchnic nerve fibers leaving the inferior hypogastric plexus innervate the pelvic viscera. Others enter the abdomen to join the aortic plexus and ultimately innervate the distal gastrointestinal tract. Concentrations of the nerves of the aortic plexus form individual celiac, superior mesenteric, and inferior mesenteric plexuses surrounding the origin of the respective vessels that they are named after. Bilateral sympathetic ganglia are found in each of these plexuses. The greater splanchnic nerves synapse at the celiac ganglia and distribute their postganglionic fibers via the branches of the celiac trunk to their target organs, which are the organs receiving their blood supply from the celiac trunk: the stomach, the spleen, the liver, the gallbladder, and part of the pancreas and duodenum. The lesser splanchnic nerves synapse at the superior mesenteric ganglia and distribute their postganglionic fibers via the branches of the superior mesenteric artery to part of the duodenum and pancreas, the jejunum, the ileum, the cecum, the appendix, the ascending colon, and the proximal transverse colon. The least splanchnic nerves synapse at the aortico-renal ganglia, which are found lateral to the superior mesenteric plexus near the origin of the renal arteries, and send postganglionic sympathetic fibers to the kidneys, which will be discussed in the solid anatomy lecture on the posterior abdominal wall and viscera. The lumbar splanchnics synapse at the inferior mesenteric ganglia and send postganglionic sympathetic nerves along the branches of the inferior mesenteric artery to innervate the distal transverse colon, the descending colon, the sigmoid colon, and the proximal rectum. The innervation of the distal rectum and anal canal will be discussed in the solid anatomy lectures on the pelvis. Preganglionic parasympathetic efferent nerve fibers from the vagus nerve pass through the aortic plexus and follow the blood vessels distally to innervate viscera from the esophagus to the proximal transverse colon, while the pelvic splanchnics provide parasympathetic innervation to the distal remainder of the gastrointestinal tract. You may recall from the solid anatomy introductory lecture that the parasympathetic ganglia are found near or embedded within the target organs. Sympathetic efferent innervation causes vasoconstriction of the blood vessels to the abdominal viscera and decreased peristalsis of the gastrointestinal tract. One can imagine that in a fight or flight scenario, it would be prudent for blood flow to be redirected from the gut to the skeletal muscles, and for digestive processes to be put on hold. Parasympathetic innervation, on the other hand, dominates when the body is at rest, resulting in vasodilation of the blood vessels to the viscera and an increase in peristaltic contractions of the smooth muscle of the gut. Visceral afferent fibers supplying the abdominal organs follow the thoracic and lumbar splanchnic nerves, the vagus nerve, and the pelvic splanchnic nerves back to the central nervous system. These visceral afferents carry information such as touch, temperature, chemosensation, stretch, and pain. Pain fibers from the distal half of the sigmoid colon and the rectum follow the pelvic splanchnics. Pain fibers from the remaining abdominal organs, however, follow the sympathetics that innervate these organs. The pain is sensed at the dermatomes supplied by the spinal nerves from the spinal cord levels from which the sympathetics arise. Consider the gallbladder as an example. Sympathetic innervation to the gallbladder comes from the greater splanchnic nerve, which arises from spinal cord levels T5 through T9. Pain from the gallbladder due to accumulation of gallstones would travel through the pain fibers running through the greater splanchnic nerve and be felt in the T5 to T9 dermatomes, which includes the lower thorax and upper abdominal walls. This sensation is known as referred pain. Pain from the parietal peritoneum may be referred to other areas of the body as well. For instance, the fundus of an inflamed gallbladder could irritate the nearby parietal peritoneum, covering the overlying central portion of the diaphragm. This portion of the peritoneum is innervated by the same nerve as the part of the diaphragm it covers, namely the phrenic nerve, which arises from the spinal nerves of C3, 4, and 5. The dermatomes of these spinal nerves are in the shoulder area, so that is where the pain would be sensed, even though the source of the pain is in the upper abdomen. Referred pain. What a remarkable phenomenon.
So that covers the blood supply, lymphatic drainage, and innervation of the abdominal organs. Now we're ready to pause the video and answer the end of session quiz questions in your study guide, and then we'll go through those answers together. All right, let's get going. First question, where does the portal vein begin? It begins where the splenic vein joins the superior mesenteric vein. Next, which vessels deliver oxygen and nutrients to the liver? We have the portal vein, which delivers both nutrients and some oxygen, and the hepatic artery, which mainly delivers oxygen. Next, how can the symptoms of portal hypertension be relieved? By surgically shunting the blood from the portal vein to the IVC. Next, what artery supplies the structures derived from each of the following embryological structures? Well, the foregut is supplied by the celiac trunk, the midgut is supplied by the superior mesenteric artery, and the hindgut is supplied by the inferior mesenteric artery. Next, what's the parasympathetic and sympathetic nervous response of the GI tract? So, the parasympathetic nervous system increases peristalsis, and the sympathetic nervous system decreases peristalsis. All right, the last thing is your mock practical, where you practice identifying structures in a timed setting. So label these images, and then you're finished. Thanks.